The part of Thomas's presentation that was just on the design is a perfect segue for where I hope to take you for the next 10 minutes. I think that the next big set of innovations in healthcare are not necessarily the technologies or the spaces or the tools that we put in place for our clinicians and our patients, but the actual infrastructure of design and innovation that we're embedding in our organizations to have ongoing innovation and design happening all the time rather than just project-based. And we're starting to see that in lots of healthcare organizations. We're starting to see different organizations building the bits and pieces of a good design structure so that this can happen. So over the next 10 minutes, I'm going to talk a little bit about Kaiser's design thinking of what we mean by that, and then a brief case study of how we've applied that. So when I say design thinking, there's lots of definitions out there, but it really is taking the methodologies of design and really thinking about how can we create structures and tools and processes and the roles that support them that are really human-centered. So a lot of folks talk about patient-centered, and human-centered for us in the healthcare world is optimizing that relationship between our patients and our clinicians. We don't want to design systems and spaces and tools that are hard for our clinicians to use but all patient-centric. We want to make sure they're optimizing that time and space between our patients and the clinicians. So for Kaiser, we are tapping into these 4 areas for design thinking. And specifically, we have our innovation consultancy, which I'm a member of. And we started 5 years ago, and we partnered with IDEO for a year and a half early on. And the purpose was to really embed the theories and methods of design thinking into Kaiser. So take those methodologies, learn them well, and be able to apply them over and over again. So that started 5 years ago, and we're adding a few more members, growing our team. We're slowly building, getting this methodology part of us. The methodology itself is pretty standard. This is a fusion of what we learned from IDEO as well as from Institute for Healthcare Improvement. Now, IDEO gave us the art of innovation, but you need more than an art form at Kaiser Permanente. We are an evidence-based organization. So what the Institute for Healthcare Improvement gave us was the science of measurement. So we kind of mashed those up together into our own methodology. So not only are we producing good design, but we're also creating the evidence that compel people to want to make the changes that we're recommending. The third piece of our strategy is around space. So we have our Garfield Center, which is out by Oakland Airport. It's a 37,000 square foot warehouse, and inside we have a fake hospital and a fake outpatient clinic and a fake home. And my favorite spot is this big open area with nothing in it, where you can prototype and let your imagination go wild. This is a place where we're really allowed to think outside the box, try new technologies, try new space configurations, try new workflows, but most importantly, see how all these bits and pieces fit together before we bring them into a live environment or build them or invest in them, and so on and so on. And the fourth piece is around networks. At Kaiser, and I think many other health organizations, we become very myopic and really constantly look internally for our solutions. The Innovation Learning Network is a group of really wonderful healthcare organizations, Ascension, CHI, partners out of Boston, Indian Health Service, Kaiser Permanente, where we created this network a few years ago to connect innovators and senior executives that are thinking about innovation to help each other learn the techniques and push each other's prototypes and innovations forward. So if I have a design challenge, traditionally I might look just inside of Kaiser Permanente, but now I have a whole host of innovators in healthcare who I can bounce my prototypes off of and who help guide me and push me forward. So an example of all these pieces come together. Last year we tackled medication administration, which the whole world was having problems with, as well as Kaiser Permanente. And in our techniques, we look at both quantitative and qualitative data. So we're trying to understand what the big issues are, and we're also trying to understand where the pain points and where the joy currently is. So yes, we have the numbers to say that there are a problem, but how do you compel people to get involved, and how do you really understand the pain points? Well, we create these interdisciplinary teams of nurses and doctors and patients, and we do something like draw your experience. So you can see 2 pictures at the corner here. 2 different nurses from 2 different hospitals. We said, draw your experience of medication administration. And remarkably, we have lots of pictures that look like this. Nurses with frazzled hair, all sticking up on end. Now, if you ask those nurses, what's the problem with medication administration, they would say, we don't have any problem. I mean, we have to work hard, we're running back and forth, and it's crazy, but it's just the way it is. But you ask them to think a little bit differently by asking them to draw or paint or whatever your technique is, and different expressions can come out. And clearly, these folks said there wasn't really that big of a problem, but the frazzled hair says something to us. And what we learned is that the process really is chaotic, full of interruptions, it's unclear, not standardized, all sorts of problems that create a very highly unreliable system. So we brought 70 nurses, doctors, patients, experts from across the country together at the Garfield Center for 2 days, where we presented these stories. We sent them off to do analogous research. So we sent them to flight school. We sent them to Safeway. We sent them to the Lexus dealership. We sent them to a forensic scientist here at UC Berkeley. Brought them out for a couple hours. They went and explored these different areas. They came back again to the Garfield Center. And for the next day and a half, they tried to tackle different bits and pieces of the medication administration challenge, and through very focused brainstorming. And they came up with over 400 ideas that would make this a better process. Then they took those 400 ideas, picked their favorite ones, the things they had passion over, and they prototyped them in 2 hours. So the stuff they had available to them, arts and crafts materials, cardboard boxes, they built for us what they thought the future would look like for them, and then they acted it out. So here you see a scene at the Garfield Center, again in my favorite spot, which is the empty space, and they quickly mocked up a patient's room, and they are showing a demonstration of what a good medication administration would be in the future. And through all these experiences, we're trying to temporarily turn our patients and our clinicians into designers, to partner with us so that these are their designs that we're co-developing with them. Here's an example of one of the ideas that started in April of 2007 at the Deep Dive, a very basic example. What I love about this is it's tangible. Most of what we do is intangible, is process design, but that's hard to show on a slide. But here's a great example of a tangible one. The nurse came up with this idea of wearing a vest that would stop everybody from interrupting her during a medication pass. And there's a whole bunch of other things that went along with it. But it was a pretty good idea. So we asked a nurse to try it for 1 unit in 1 shift a month later, and we bought a construction vest at the Home Depot. And what we found out is that conceptually the nurses loved it. They felt protected. They felt like they could really focus in on medications, but they hated the vest. They thought it looked like construction workers. So we said, well, what will make that better for you? And so they suggested a sash. So we tried a sash that was in Hayward in June of 2007. And this young lady said she felt safer, she felt more comfortable and confident, but she felt like she was going to church. And we said, well, how can we fix that? And she said, well, try to make it a little sleeker and sexier. And so we came up with red vinyl, which is in Hayward just a month later. We thought that was sexy. And indeed, nurses were feeling better and better about what we were producing. And just a couple months later, we ended up with the final design, which is that glowy, reflective material, which is now called no interruption wear. Just, I think, a really nice, simple example of a concept that probably could have failed early on if we went with what the outcome was rather than the concept. So this is conceptually a fail, but every failure, conceptually, we succeeded. And in the end, we came up with a great design. This happens to be a part of an innovation we call KP MedRight, which is made up of 3 pieces that came out of this. So again, we started with 400 fabulous, crazy, terrible ideas, and we whittled it down over the summer and came up with 3 pieces. The foundation is the process. So the new behaviors that are human-centered create a much safer, warmer medication experience for the patient and the clinician. The no interruption wear, which is that yellow sash to kind of support the process, and a sacred zone in front of Pyxis machines or where they pull medications. Again, just another reminder of being safe during this experience. What we found is at baseline, we were only achieving about a third reliability for a good medication pass. And the definition of reliability is up there. I'm not going to go into that. But what we were able to achieve just 1 month later was going from a third to about 75% reliable, and 2 months later hitting around 80%. And now we're up to over 90% reliable. And the reliability is a common definition across the industry. So we are way, way better off than we were prior to this initiative. And we now have this pilot, which was in just 2 hospitals and 2 units, now in all hospitals at Kaiser Permanente, except for our Southern California region, which is 11 hospitals. They're kicking off at the end of this year. So next year, we should have all of our hospitals up and running on a standard, human-centered way of doing medication administration. There are also some really futuristic ideas that come out of our work. So if this is the stuff that we can do now, they also do think of some really great stuff that is just kind of out there and we're not able to pull off just in a few months. So this was an idea about a medication room of the future. They have some really great ideas, task-based lighting. We know that our nurses are getting older and they're having a harder time reading the medication bottles and the pills. And so their concept is that in medication rooms, as they approach the different medication areas, they'll get extra illumination that not only illuminates, it reminds them where they belong, gives them the illumination to read better, but when they move out of that area, it then shuts itself off, and the next task area lights up, so it brings them through a natural workflow through the medication room. Pretty unique concept. Some of these ideas, although futuristic, and we do mock them up, that picture doesn't really do it justice of what it looks like mocked up, are starting to leak their way into our national facilities. So we're not always sure what we're going to do with these futuristic ideas, but just by prototyping them and putting them up once, it does start influencing what the future could look like and feel like. So here is just a one-page case study summary of what I just went over. The orange is the infrastructure of innovation and design, and that's what I think really is key for everything I've just shared with you. And again, we're seeing lots of organizations starting to put these bits and pieces in place. So along the top is a timeline, starting with observations. I told you about drawing pictures and visiting with our patients and clinicians, all the way to the very end of implementation. So the orange bar is our group, the Innovation Consultancy, administering the innovation method of design. And the little circles are the Innovation Learning Network. So that network of innovators across the United States, 5 times they influenced our design. Early on, we had 2-hour sensing sessions. So the Veterans Administration, Ascension Healthcare, and partners all did 2 hours, the best and worst of medication administration. All 4 our organizations jump-started each other's innovation work because of that those sessions. They then joined us during our deep dive at the Garfield Center. So although it was mostly Kaiser, we had several members from the ILN come and participate in our designs and help influencing our thinking. And then, of course, the infrastructure of the Garfield Center itself, a place to innovate and bring people together to do better, good, human-centered design. So that's all I got. I hope that you think that design thinking is something you should explore. Thank you.